GC Klani sir doesn't need any introduction because he's a well-known personality in our country. He's the person who did work a lot in the field of sleep medicine, respiratory disease, association with sleep medicine, pollution and respiratory diseases. So don't we waste time. I start. He is chairman of PCR Institute of Pulmonary Critical Care and Sleep Medicine. Formerly, he was professor at in AIMS, Department of Pulmonary Critical Care Medicine. He has many affiliation, achievements, and award. He was oversee fellow critical care at Mount Sinai Medical School in USA. He was fellow and global governor of American College of Chest Physicians in USA. And he has more than 250 publications in national and international journals. And he's also a member of WHO Technical Advisory Committee on Airway Pollution. So I request Klani sir to start.
So, ladies and gentlemen, obesity and sleep apnea. Why we are talking about it? You can see a person who's obese and just somnolent. And we were actually, when we were young, school children, somebody who is snoring, we used to say he's sleeping much better. You know, he's in the deep sleep. And what I remember reading during my MD time was Pickwickian syndrome, obesity, hypoventilation syndrome. But as the science has progressed, we have realized that obesity, along with causing hypertension, diabetes, CAD, osteoarthritis, and number of problems. But obesity and sleep is a big sign. And I must say that, it's not possible for me in this period of 25 minutes to cover everything about obesity and sleep, but I would be able to give you a bird's eye view. There is an obese person, wherever he sits, he just sleeps. There's another obese person who is quite alert, he's equally obese. So what is this? What is this relationship of obesity with sleep? So I would start with the basic changes which takes place in the respiratory system in obese people. And there is obesity. It leads to reduction in lung volume. As you can see, as a respiratory physician, I must talk about this first. There's reduction, the total lung capacity goes down, the functional residual capacity goes down. Actually, it is the expiratory reserve volume which goes down drastically. With that, the whole volume is reduced, and there are some mechanical effects which we must understand. The decrease in the diaphragmatic movement, there is decrease in the lung compliance, there is the decrease in the FRC. You can see a lot of fat in the chest wall. There's a fat below the diaphragm, and this leads to decrease in the lung compliance, and there's increase in the lower airway resistance. And overall, there is an increase in the work of breathing, and which needs to be compensated by elevated drive in the respiratory centers and respiratory muscles. So these are the respiratory effects of, and what it leads to ultimately, it leads to obstructive sleep apnea, and I'll be spending majority of time on that. It also leads to obesity hypoventilation syndrome. So can we divide sleep disordered breathing into obstructive sleep apnea and obesity hypoventilation syndrome? Yes and no. Because 90% of the patients who have obesity hypoventilation syndrome also have obstructive sleep apnea. But for the purpose of discussion, I would be dividing it into two. So what is a sleep apnea? Sleep apnea means the repetitive episodes of pause and respiration for more than 10 seconds, or for the duration associated with fragmentation of sleep, arousal, and most importantly, reduction in oxygen saturation. What is hypoapnea? Decrease in airflow to 50%, some people take it as 25%, which is associated with oxygen desaturation of 4% and or arousal, EEG arousal. So therefore, And if you both combine, that is called apnea hypopnea, and that is the index that is used for narrating the severity. So sleep apnea can be obstructive, can be central, or what we call as OHS. We will not be discussing central sleep apnea, which is a neurological condition, or as I said, it can be both. So what happens in the obesity? As I said, all obese person do not have sleep apnea. Now this is a person who is obese, his BMI is 35, his AHI is 59, apnea hypopnea index, because his tongue volume is too large. And this is the yellow thing is the fat content in the tongue volume. The another person who is equally obese, the BMI of 35, but his AHI is only 9.6 and his tongue volume is less and the fat content is also less. And what happens in the obstructive sleep apnea? And I like to draw your attention to this cartoon. In the normal breathing, there is a tongue, there is a soft palate, there is a uvula, and breathing is normal. Person breathes normally, exhales, and what happens during snoring? The sound comes only when the airway becomes narrow. You can see that this turbulent flow of air, which which gives rise to snoring, and ultimately when the sleep becomes deep, the breathing completely stops. This is what is called as uh, apnea and hypopnea, and that is what the mechanism of. And why in the obese patient? Of course, the 70% of the patients who have obstructive sleep apnea are actually obese. So there is a increased fat deposition in the in the in the parapharyngeal fat. There is a diminished protective reflex that maintain airway patency. There is a fat deposition around abdomen, decreases lung volume, causing diminished oxygen store, and there is excess fat deposition in the upper trunk. And how common it is? Now, if your BMI is less than 25, then chances of having obstructive sleep apnea are less than 5%. If it is BMI is 25 to 29, which is called overweight, it is little more than 5%. However, if the BMI is more than 30, then there is almost 30% chance, both in males and females, that there will be obstructive sleep apnea, which can go up to 90% if the BMI is something like 45 and 50. In the pre-menopausal time, the incidence of OSA is much less in females as compared to males, but in the post-menopausal, like in cardiac diseases, it is the same. So about 70% of patients with OSA are obese. This is an Indian study. And prevalence of OSA in obese men and women is about 40%. Higher BMI is associated with high prevalence. So if the BMI is more than 30, the 6% patient will have AHI of more than 5. If the BMI is more than 40, 98% will have AHI of more than 5, which is actually an, a number which is used for diagnosing OHA. So as the BMI increases, as I said in the ladies also, the BMI is 25 to 30 is 20%. This is another study which is shown. And if it is the BMI is more than 40, it goes up to 74%. So what are the risk factors? The main risk factor is, of course, BMI is more than 30. Neck size, collar size of 17 inches in males and 16 inches in females. As I said, is relatively more common in males. Besides that, macroglossia, a tonsillar hypertrophy, nasal septal deviation, micrognathia, narrowing of the hard palate, and class 3 by 4 modified 3 or 4 Mullen-Patti score, which I will be showing. And there are some genetic disorders, endocrine disorders like hypothyroidism and alcohol, sedative, and hypnotic use. Some of the majority of risk factors are modifiable. So what are the clinical consequences? Why it is important? As I said previously, we were thinking those who snore sleep better. Of course, they sleep well. But what are the consequences? These patients have snoring, there is witness apnea, there nocturnal awakening. Sometimes they sit with the feeling of choking sensation and then go to sleep. They go frequently for urination and they always think that it's because of the prostate problem, but actually it's not because of prostate problem. Majority of time, nocturnal sweating, and most importantly, when they wake up in the morning, they don't feel fresh. You tell them you go for a walk. They say, doctor, I don't feel like, I don't, and then they want a cup of tea and coffee. There's a early morning grogginess and headache. And of course, the daytime somnolence is the most important. And in the United States, the most common cause of car accidents is actually sleep apnea. And there's decreased libido and impotence, and person is irritable, memory loss, and personality change. So there are several of these changes which can, and people live with it for ages. And of course, person sleeps wherever, person may cashier while counting notes, he may sleep. The wife or bed partner gets fed up with the, snoring. And as I said, the accidents are the most common. But that's not enough. There are metabolic consequences which are very important, which leads to reduced lifespan as well as, so if there is obesity, which leads to systemic inflammation. There is metabolic syndrome associated with, which includes hyperlipidemia and hyperglycemia. And there is systemic complication, which in the form of hypertension, left ventricular hypertrophy, endothelial dysfunction, atrial fibrillation is very important association, and inflammation, and it leads to obesity, hypoventilation syndrome, pulmonary hypertension, and core pulmonary. And ultimately, what it leads to is the atherosclerosis, ischemic heart disease, peripheral vascular disease, leading to high morbidity and as well as mortality. So not only the quality of life is affected, the the span of life is also curtailed. So how do we diagnose? How do we suspect? I have already told you the symptoms. How do we diagnose obesity? Obstructive sleep apnea. For the diagnosis, the history is most important. You have to take meticulous history. The cholesterol history of bed partner is extremely important. The history never complete without asking the. You ask about the snoring, loudness of snoring. You ask about witness choking, and that is only a bed partner can tell you. And of course, the sleep pattern that you have to ask. So how do we assess the daytime somnolence? There is the Epworth Sleepy Scale, which is the most commonly used. There are several other scales also. Sitting while reading, watching TV, sitting in the inactive place as passenger in a car, so on and so forth. They are scored from 0, 1, 2, 3. Patient does it. And a score of more than 10 is considered significant for daytime somnolence. If the score is more than 10, then you have to go further for the sleep study. Now, on the physical examination, the neck circumference, as I said, in males more than 17 and females more than 16 inches is important. The oral cavity, the tongue size, the presence of narrow arched palate, tonsillar enlargement, retrognathia, micrognathia, and crowded oropharynx is important. Nasal septum deviation, swollen turbinates, nasal polyps are all important. And Malampati score. Now, we who are practicing sleep medicine, we ask the person to open the mouth without asking him to say ah. And if you see something like this, the next thing we know that this person definitely snores and is very likely to have OSA. Similarly, this patient, and these are unlikely to be associated. So Malampati score, but important thing is not the patient to say as you do for ENT examination. Just ask him to open the mouth. Among the investigation, you always do a lipid profile, sugar, thyroid scanning, and all those things. As far as the sleep study is concerned, the laboratory-based polysomnography is what is recommended. But nowadays, the people don't want to come to hospital because they want the comfort of sleeping in their own bed. So home sleep study is also important. It depends upon what level of study you want to do. So the polysomnography involves the EEG, it requires the airflow, it requires ECG, it requires oxygen saturation, abdominal movement, and chest wall movement. What happens in obstructive sleep apnea? You can see this is airflow has stopped. Okay, the airflow has stopped. This is apnea, but what is happening that thorax and abdominal muscles are working. So and this leads to sort of choking. It leads to sleep fragmentation. It leads to arousal. And arousals are measured by electroencephalogram. The airflow is measured by a meter, uh, a sensor which is put in the nose, and this is measured by the leads which are put on the abdomen and this. And this is the main test, and you can do variety of studies. So how do we do the severity? If the AHI, that apnea and hypopnea index, apnea means when the breathing stops for more than 10 seconds, hypopnea when the breathing flow becomes less than 50% with desaturation of 4 or 4% or the arousal, we call it AHI. If the AHI is 5 to 15, it is mild. It is 15 to 30, it can be moderate. If more than 30, it's severe. In practice, you would see a patient with AHI of 50 and 60. So in an hour's time, their breathing slows down for 50, 60 times, and that's what severe. So how do I treat it? The management of OSA is a multi-prong. It's not only giving a CPAP machine or surgery or dental appliances. I would be focusing on weight reduction. Extremely important. 1% change in weight is associated with 3% change in AHI. And OSA severity is reduced and in some patients abolished also. Unfortunately, in my practice, very few patients are able to attain that. But I know patients who have reduced 10, 15, 20 kilos of weight and sustained it. And they have got rid of obstructive sleep apnea and got rid of CPAP machine. But some patients will actually require bariatric surgery. And these patients generally have coexisting obesity hypoventilation syndrome, which I'll be talking about. Pharmacotherapy, antidepressants, respiratory stimulants, CNS stimulants, and hormones have been tried, but they do not significantly improve AHI or apnea index. In fact, if you give antidepressant, they have some sedative effect. They would actually enhance sleep apnea. Oxygen therapy is only used when desaturation is severe, and usually it is associated with obstructive sleep apnea. Now, this is the depiction of impact of weight loss. This is the 158 kg person with so much of fat and so much of narrowing of the airways. When you reducing weight or after bariatric surgery, reduction in 50 kilos of weight loss, the BMI goes down to 29 and the fat goes down and the airway becomes patent. So this is what happens when the benefit of weight loss. There are other measures which can be used for mild, like promoting sleep lateral position. Sometimes you tie a tennis ball at the back, and so that person is unable to. The apnea is always more in supine position. So sleeping on the left lateral or right lateral. Sometimes the role of raising the head of the bed, that's actually not very clear. There are ways of pharyngeal muscle stimulation, which is actually an area of research. I have never used it. But what is important is continuous positive airway pressure. What is continuous positive air pressure? It's like giving a continuous pressure. It's a reverse of a vacuum pump in a way. You can also use bilevel positive pressure more for severe OSA and OHS. And you can also use auto titrating PAP, what is called auto CPAP. That is, instead of giving a fixed pressure, the machine itself decides. This machine is more expensive, but the studies have shown that all fixed CPAP is better than auto CPAP. But to use fixed CPAP, you have to titrate it in the hospital where the person actually titrates to achieve a AHI of less than 5. Oral appliances can be used, but they are a little difficult to use. But dental surgeons are fond of it. There are mandible enhancement devices which can be applied in the night. So CPAP remains the mainstay of treatment. It improves symptoms and quality of life and significantly decrease AHI. When we give CPAP machine to a person who has daytime somnolence, early morning grogginess, the immediate benefit is that his sleep quality improves. He stops waking up in the night for going to the washroom. He gets up fresh in the morning. Daytime, he feels his life is different. He doesn't require much of tea and coffee and smoking to keep himself active. But that's not the only benefit. The CPAP has been shown to improve the blood pressure to some extent. And also there's some evidence that cardiovascular complications, atherosclerosis, heart attacks, and brain attacks are also reduced. And of course, it significantly decreases the AHI. Of course, surgery, you will be listening a full lecture, so I'll not be talking about. There are nasal, palatal, and tongue surgery and maxillary. These things will be discussed in detail, so I'm not touching it. And these are the mandibular advancement devices, of which I am not an expert. But it should be understood that dental appliances are useful only in mild to moderate OSA. They are never useful for severe OSA. So I'm coming to the next part of my deliberation, and that is obesity hypoventilation syndrome. And this is a picture that we are familiar with, the Pickwickian syndrome, which we were reading during our MBBS and MD time. The OHS, as I would call it, is defined as obesity, which is more than 30 kilogram per meter square, sleep disorder breathing, and most importantly is daytime hypercapnia. And this I must say that in my place working as an intensivist in the ICU, quite often patients come with acute type 2 respiratory failure and treated as COPD without realizing that actually they are suffering from obesity hypoventilation syndrome. There is sleep disorder breathing, as 90% of these cases have OSA also, and there is non-obstructive sleep hypoventilation. However, to diagnose this, you have to rule out COPD, ILD, chest wall diseases like kyphoscoliosis, severe hypothyroidism, neuromuscular disease, and congenital hypoventilation. Don't jump to the diagnosis just because the person is obese and he has a rise in carbon dioxide. It carries a high morbidity and mortality. In fact, in 1 year time, 15% mortality is there because of the various reasons. So the hallmark is hypoventilation, which leads to PaCO2 rise of more than 45, exclusion of other causes, and sleep disorder breathing is there. And then you call it an obesity hypoventilation syndrome. What is the pathophysiology? As I've already discussed right at the outset, that there's obesity-related change in respiratory system. There's breathing abnormality during sleep, and most importantly, there's alteration in respiratory drive. And that is what leads to obesity hypoventilation syndrome. I would like to draw your attention to this particular graph. During sleep, now this is the airflow that you see. Now as the sleep becomes deep and person has OSA also, the airflow goes down. This leads to accumulation of carbon dioxide. But soon the breathing starts again with more vigorous force, as you can see. More vigorous force, it leads to CO2 elimination. Finally, when there is apnea for a longer time, it leads to CO2 accumulation, which is more. And over a period of time, there is a persistent CO2 elevation, which is a hallmark of uh, obesity hypoventilation syndrome. What ultimately happens that there is a decrease in response to carbon dioxide rise, and there is which leads to slow rate of bicarb excretion, leading to blunted respiratory drive and rise in CO2 and rise in bicarbonate, and which becomes a surrogate marker of obesity hypoventilation syndrome. So, as you can see, if there is a short apnea, the CO2 does not rise. When the apnea is longer, the CO2 will go up, and this is the hallmark of obesity hypoventilation syndrome. So, the hallmark is why there is a blunted respiratory drive. There is a REM sleep hypoventilation. There is a obesity-related mechanical constraint, which I have already described. There is a reduced central respiratory drive. Leptin, which is a powerful stimulator of ventilation. In OHS, there is central resistance to leptin because of obesity. And it has several other effects. This leads to deterioration of respiratory control, and which leads to daytime hypoventilation. So the ERS and American Thoracic Society and European Society have given definition. So both are actually same. The obesity, sleep disordered breathing, and daytime CO2 are more than 45, where you rule out other causes. How common it is? Obesity hypoventilation syndrome. If the BMI is 30 to 35, there is a 5% chance the person will have obesity hypoventilation syndrome. If it is 35 to 40, there is 10%. If the BMI is more than 40, 20%. So if the person has BMI of more than 20%, there is 20% chance. Why I am telling you this? That if you have a person who comes to you who has a BMI of 40 or 45, he doesn't have any symptoms. You have to ask him about sleep disorders, breathing, snoring and everything. Do a PCO2, daytime ABG. It's very likely there's 1 in 5 chance that you will find the CO2 would be high. If you don't want to do that, just do a bicarbonate estimation. If it is more than 27, then this patient requires a further investigation by doing an ABG and sleep study. So how do we diagnose obesity hypoventilation syndrome? Now this is the ATS document, which see that if the CO2 is high, then it's very likely, this is recommendation 1A, that OHS is there. Now, if there's with lower moderate probability of OHS, then you do a bicarb. If the bicarb measures is high, you do PCO2. The bicarb cutoff value of 27 was the only one in which a pooled analysis could be performed. So therefore, it's very important to suspect. It is very important to diagnose and treat. And finally, polysomnography is essential. 90% of these patients will have OSA along with that, and severe OSA is more commonly associated with OHS. So it goes both ways. If the person has severe OSA with an AHI of more than 30, think about obesity hypoventilation syndrome, and 10% patient may have hypoventilation also. So this is the REM sleep that you can see. There is absent flow, and the CO2 goes up and oxygen goes down. Here you can see the effect of obesity hypoventilation syndrome, as well as the coexistence of obstructive sleep apnea, and you can see that CO2 oxygen goes down and CO2 starts rising to up to 60 and 70 in the night, which can be measured by end-tidal CO2, which can also used by percutaneous measurement. Another thing, what happens during REM sleep, that there is a oxygen goes down, there is hypoventilation, and CO2, CO2 goes up. Oxygen goes down, CO2 goes up, which is associated with diminished respiratory drive. And this cartoon I showed you before also, this picture, there's a apnea, and this when the apnea goes for a longer time, there's a rise in the CO2. So hypoapnea, OSA and OHA would generally coexist and rising CO2 is demonstrated. Initially the CO2 is 21, 23, 38, 42, 45. It keeps on rising as the person goes into the deeper sleep, and this is a hallmark of OHS. Finally, how do I manage obesity hypoventilation syndrome, which is different from managing OSA? The goals of treatment is normalization of CO2 during wakefulness and sleep, elimination of desaturation during wakefulness, relief of symptoms, treatment of underlying OSA, improvement of sleep architecture and quality of life, prevention of complications including pulmonary hypertension and cor pulmonale. OSA is not associated with cor pulmonale, but OHS is associated with cor pulmonale as well as acute type 2 respiratory failure. People quite often first time land up in the ICU with type 2 respiratory failure with acute respiratory acidosis, and then we know that they are suffering from obesity hypoventilation syndrome. So the question in the young mind comes, do they all require BiPAP or non-invasive ventilation, or CPAP is sufficient, or we can use what is called AVAP, and I'll be talking briefly about this. Weight reduction is of course important. Now OHS is one disease where bariatric surgery is very useful. If the BMI is more than 40 and you think that if this person is unable to reduce weight for whatever reason, is willingness or it failed, bariatric surgery leads to a lot of improvement. Is there a role of drugs? Is there a role of tracheostomy? I'll be talking briefly. So the positive airway pressure therapy is important for managing OHS and OSA, and it is also useful for acutely decompensated OHS which present in type 2 respiratory failure and also in patients who fail CPAP therapy. Now, what are initially the ATS, American Thoracic Society, recommends that initial treatment of obesity hypoventilation syndrome is not BiPAP. The CPAP is sufficient in several studies. In fact, in an international conference, I confronted the best experts and why not BiPAP at the moment, at the outset. But they said that this is what the evidence says. So these people have higher baseline AHI. There is a less restrictive physiology on PFT and less severe desaturation. So initial treatment of OHS is CPAP. Now, some patient will fail CPAP. Some patient will come in acute type 2 respiratory failure. And CO2 will continue to be high with AHI, which will be high, and patient being symptomatic. There you use IPAP, and also that is you use bilevel positive air pressure. And so how do you titrate? You keep on increasing. You start the low IPAP and then you keep on increasing slowly. PS should be increased every 5 minutes if the tidal volume is low. So when you are using a critical care ventilator machine where you measure the tidal volume also, so you start with the pressure support or what you call as BiPAP. or NIV. Some people don't like to use BiPAP word when you use a critical care ventilator. You start with the smaller IPAP, smaller inspiratory pressure, and look at the tidal volume. Till the time you reach tidal volume at about 6 milliliters per ideal body weight, and you should increase the pressure support if the arterial PCO2 remains 10 millimeter high or more above the PCO2 goal at the current setting of 10 minutes or more. An acceptable goal of PCO2 is a value less than or equal to that awake. Suppose the person has awake CO2 of 45, you aim at 45. You don't try to bring it to 35. That's not a good thing to do. And pressure support may be increased if the SpO2 remains below 90% for 5 minutes or more. So therefore, it requires a titration on the part of the pulmonologist and intensivist when you are doing a NIV titration in patients with obesity hypoventilation syndrome. Now, this is a study which is published in the Annals of Thoracic Society in the year 2020. This included a large number of patients where patients with OHS with or without OSA and compared PAP to CPAP therapy. The age group is 45 to 74. PAP was delivered as NIV, most commonly bi-level positive air pressure. Patients with both PAP and no PAP group were typically given counseling with lifestyle modification. So these are the
Sir, we are
differences.
running short of time, sir. Please end
Just
the surprise.
this is the last slide, sir. Last 3-4 slides. So there is so the CO2 improved with PAP therapy. So all the parameters, awake hypoxemia improved, the AHI improved. You can see a distinct increase with PAP therapy. The quality of life improved, and daytime sleepiness also improved. So ATS recommendation said for stable ambulatory and diagnosed with OHS, we should give treatment PAP therapy. And there is long-term follow-up also, whether you should give CPAP or BiPAP. The inference is that stable patients with OHS and COSA, NI and CPAP have similar long-term effectiveness. So therefore, the initially PAP and then you can try BiPAP. Now, AVAPS is a average volume assured pressure support. This is a sort of advanced mode which gives a assured volume and pressure. I have no time to go into this. As I have already said, that bariatric intervention associated with robust outcome. So all patients with OHS who have more than BMI of more than 40 should be considered for bariatric surgery. Respiratory stimulant, medroxyprogesterone, acetazolamide has been tried, but I would say they are of no value. And now this is a take-home message. Both OSA and OHS are associated with obesity, which is the theme of this conference. The best managed of OSA is with CPAP, to my mind. Obesity, hypertension, diabetes, and sleep disorder breathing are associated with high morbidity and mortality. In fact, this has been included in the metabolic syndrome now. Awareness and high index of suspicion would lead to the diagnosis. Best screening of OHS is daytime PCO2 doing ABG. When suspicion is low, a screening can be done with Vicar also. Majority of OHS patients can be treated with CPAP. Acute presentation of OHS should be treated with bi-level PAP therapy. Respected Chairman and ladies and gentlemen, I am really thankful to you for your kind attention. Thank you.
Thank you so much,
Is
sir.
there any questions I could answer? I don't know whether it's feasible.
Any questions from the audience? Thank you, sir. Thank you for such a wonderful and enlightening us on obesity, hyperventilation syndrome, and OSA.
Thank you. Thank you.
Thank you, sir.
Thank you so much.